Hello.
You are audible, Dr. Mohit. Go ahead.
Hello. Definition for hypoxic pulmonary vasoconstriction is a contraction of the vascular smooth muscle in the pulmonary circulation in response to the lower region for partial pressure of oxygen. It is important mechanism for matching the regional perfusion and ventilation in the lungs. The physiology behind the hypoxic pulmonary vasoconstriction. The systemic circulation dilate in presence of hypoxia, in contrast to the pulmonary circulation, which vasoconstricts. This response of the pulmonary circulation is known as a hypoxic pulmonary vasoconstriction, and is protective physiological reflex that aim to divert the blood flow away from the hypoxic area of the lung to the area with better ventilation and oxygen. The ventilation perfusion mismatching. The matching of the alveolar ventilation and perfusion is a determinant of gas exchange. The ventilation to perfusion ratio tend to differ slightly throughout the different region of the lung. For example, at the apex, more ventilation with less perfusion at the apex. That's why high V by Q ratio. At the base, there is a more perfusion and less ventilation. That's why at the base, it's low V by Q ratio. The V by Q ratio at the upper zone of the lungs, 3.3. The middle zone, V by Q ratio is 1, and at the base is 0.63. The HPV reflex aims to improve the matching of the ventilation and perfusion, although its role is value to the minimal in normal healthy lung with already well-matched ventilation and perfusion. In contrast, the role of HPV is much more significant in chronic respiratory disease such as chronic obstructive pulmonary disease (COPD) and interstitial lung diseases. The heterogeneous nature of the lung in this disease means that the local regional response such as with HPV is long-term adequate oxygenation. Inappropriate delivery of supplementary oxygen in this scenario, in addition to the some drug, can attenuate the HPV, then worsen the AV by Q matching and lead to the deterioration in the oxygenation. Unfortunately, the chronic exposure of the pulmonary circulation to the area of high resistance also contribute to the development of irreversible pulmonary hypertension, right ventricular hypertension. Acute VQ mismatch is commonly cause of the hypoxia and acute respiratory disease such as acute asthma, pneumonia, pulmonary embolism, and pulmonary edema. The HPV is likely to offer the beneficial effect in this clinical setting by redirection of the pulmonary blood flow to the area of better ventilated lung, so improving the VQ match. The mechanism behind the HPV is stimulus for the HPV is tissue partial pressure oxygen in the region of pulmonary arteriole. It determined by the two factors. The first one is partial pressure of oxygen in the alveoli, that is PaO2, and mixed venous blood, PvO2. The site of action for the HPV is in the pulmonary arterial smooth muscle cell. This causes the increase in the calcium ion binding to the calmodium, activating the myosin light chain kinase, and ultimately leading to the contraction of the smooth muscle. At the cellular level, there is a special cells PASMC. The potassium voltage gated potassium channel are there that are oxygen sensitive. In presence of the hypoxia, it get inactivated. That's why the intracellular concentration of the potassium get increased. Ultimately lead to the depolarization of the cellular membrane and the increase in the influx of the calcium. That increase in the intracellular calcium ion cause the pulmonary vasoconstriction. This is the mechanism of HPV at cellular level. Then there are some mediators, local mediators uh, for this vasoconstriction. That is nitric oxide. Nitric oxide is continuously produced by the pulmonary endothelium cell. It maintains the constant state of pulmonary dilatation by reducing the intracellular calcium, relaxing the smooth muscle. Hypoxia reduce basal nitric oxide production, and thus HPV is enhanced. Then the next mediator is prostacyclin. Prostacyclin is a vasodilator that stimulates the cyclin adenine cyclase and increase the CAMP. Then endothelium. Endothelium 1. Endothelium 1 is a small peptide paracyclin mediator that potent vasoconstrictor properties. It acts via the CGAMP on PASMC. HPV in the human has two distinct temporal phases, that phase 1 and phase 2. Phase 1 begins within the few seconds and is maximal at 15 minutes and most probably mediated by the potassium channel. When the moderate hypoxia is sustained for more than 30 to 60 minutes, the phase 2 begins and the further increase in the vascular resistance is seen and reaching peak at 2 hours. This phase is most probably result increase the release of endothelium. When the normoxia return, it can take several hours to pulmonary vascular resistance to return to the baseline. Then physiological factors influencing the HPV. The factors that increase the HPV response are hypercapnia, hyperthermia, acidosis, and iron deficiency. That on other hand, the decreased HPV response by hypocapnia, hypothermia, and alkalosis. The age has an influence upon the HPV response. At the birth, the HPV mechanism is more pronounced. The HPV response is intense in infant, but this decline in the first few hours of the life. The HPV response becomes highly significant in anesthesia for pediatric congenital cardiac surgeries when the balancing between the pulmonary and systemic vascular resistance is crucial. The clinical implications of HPV. The first clinical implication is general anesthesia. General anesthesia leads to the atelectasia, alternate ventilation and perfusion matching, an increase in area of both high and low VBIQ ratios. The supine position, changes in the chest wall, diaphragm shape, altered regional lung compliance, and the distribution of positive pressure ventilation all contribute to this. All volatile anesthetic agents inhibit HPV in dose-dependent manner, with older agents such as halothane having a greater effect. There is doesn't, but with the newer modern volatile anesthetic agent like ISO, CO, and desflurane in their inhibition of HPV at equimax doses. The effect of nitrous oxide is not yet clear, but it's been demonstrated to increase PVR, pulmonary vascular resistance, and should be cautiously used in patients with pulmonary hypertension. The propofol does not have effect on HPV. Using an unnecessary high fraction inspire oxygen concentration during the general anesthesia may not only contribute to the obstruction atelectasia, but it in the ventilated area this will inhibit the HPV, so potentially affect the V by Q matching. Then second clinical implication, one lung ventilation. One lung ventilation is indicated for thoracic surgical procedure for prevention of cross-contamination of the lungs and to control the distribution of ventilation. That is, in case of bronchopleural fistula. The patient who require OLV, one lung ventilation for thoracic surgery, are placed in the lateral position. The lower dependent lung is ventilated and the upper non-dependent lung is allowed to collapse. At the lung collapse, BVR is increased because of low lung volume and alveoli become hypoxic, activating that hypoxia lead to activating the HPV, so redirecting the pulmonary blood flow away from the normal lung. A failure of the lung to collapse or ineffective HPV response can affect VIQ matching and oxygenation, and hypoxia remain the common concern during the one lung ventilation. The thoracic epidural have no effect on the HPV mechanism. The vasopressor drug used during the anesthesia to treat the systemic hypotension during the one lung ventilation are unlikely to have the major influence on HPV, although alpha 1 agonist may enhance the response. Pulmonary hypertension. The pulmonary hypertension is defined as the mild pulmonary artery pressure at rest more than 25 mm of Hg. Mild pulmonary hypertension when the pressure is between 25 to 40 mm of Hg. Moderate pulmonary hypertension when the pressure is between 41 to 55 mm of Hg, and severe when more than 55 mm of Hg. The pulmonary hypertension can manifest acutely or chronically. and those who need major emergency surgery. The endotoxin released in the sepsis are known to play the significant role in the development of acute PH. There is the excessive release of inflammatory mediator that disturb the balance between nitric oxide, endothelium, and prostanoid in the pulmonary vascular capillaries. The severe acute PH can lead to the life-threatening situation of refractory system arterial hypertension, severe hypoxia, right ventricular failure, and ultimately cardiogenic shock. The choice of inotropics and vasopressors in the patient with shock and severe PH should take into consideration their effect on VPH and PVR. The balance has to be struck to inhibit the VG and dilate the pulmonary artery, with the need to maintain the systemic blood pressure to maintain the pulmonary artery perfusion pressure. Some have advocated using the vasoconstriction treatment such as nitric oxide, prostaglandin, and other phosphoesteroids. PDE inhibitor are other treatment choice for severe PH. Then acute respiratory distress syndrome (ARDS) is an diffuse inflammatory lung injury lead to the increased pulmonary vascular permeability, loss of aerated lung tissue with hypoxia and bilateral radiograph opacity. It associated with increased physiological dead space and decreased lung compliance. In ARDS, both HPV and pulmonary vascular damage can lead to the pulmonary hypertension and right ventricular dysfunction. The impact of hypoxia, hypercapnia, lung volume, PEEP, atelectasia can all have physiological effect on activity of HPV. The extreme of lung volume, high plateau pressure should be avoided. The PEEP can be used to recruit the ventilated area of the lung atelectasia to promote the ventilation and perfusion matching. The ARDS management The ARDS management is the optimization of ventilation. Nitrous oxide has constantly failed to show the improvement in mortality in ARDS patients and now is infrequently used. The attempt to manipulate the HPV are challenging as pulmonary artery pressure are infrequently directly measured, and echo measurement can be difficult and unreliable with high ventilatory pressure. Even so, the important to remain aware the strain on the right heart from the disease pathology. HPV and ventilation strategies normally apply. The attitude sickness. The attitude sickness is commonly used term for syndrome encounter at altitude more than 2,500 meters. In this environment, the HPV is trigger in all the lung region and response can be become exaggerated. The attitude sickness there is increased sympathetic tone and very active HPV, resulting in uneven pulmonary vasoconstriction, leading to the overperfusion for some region of the pulmonary vascular bed. The increased pulmonary vascular capillary pressure then lead to the stress failure of the pulmonary capillaries. The end result is a patchy accumulation of extravascular fluid in the alveolar space that impair the lung function and can, in severe instance, prove fatal. The management of altitude sickness, immediate descent, and adequate flow of the supplemental oxygen. Dexamethasone can reduce the HPV response and can be used to prevent and treat the HAPV. The calcium channel blocker nifedipine is another drug to prevent and treat the HAPV. The next point is drug effect on HPV. First drug is uh, 1-PDE inhibitor. The 1-PDE5 inhibitor group, that is sildenafil, is established oral therapy for pulmonary hypertension. It inhibits the HPV via impairing the cGMP breakdown, potentiating the nitrous oxide and increasing the PSMs. The PDE3 group of inhibitor, that is milrinone, increase the CAMP and lead to the augmenting the myocardial contraction with the dilatation of pulmonary vasculature. The next drug is inhaled nitrous oxide. Inhaled nitrous oxide is a potent pulmonary vasodilator. Nitric oxide selectively reduce the PVR and improve the cardiac output in pulmonary artery hypertension. It is used in pediatric intensive care unit as a therapeutic option to treat the respiratory failure with severe pulmonary hypertension in young patients. The prostacyclin analog are potent systemic and pulmonary vasodilator that also have the antiplatelet and antiproliferative effect. The example of the pharmacological agent include epopostal, treprostinil, and elo, iloprost. Delivery options include the IV infusion and inhalation. They reduce the fever and use in treatment of the patient with pulmonary hypertension. The next is catecholamines. The catecholamines with beta receptor effect, epinephrine, dopamine, dobutamine, inhibit the HPA response at standard doses. The dobutamine can be used to augment right ventricular functions and reduce the PVR. It does not uh, it does also reduce the systemic vascular resistance, leading to the systemic hypertension, which is important to anticipate. The vasopressor with predominant alpha 1 action, that is norepinephrine and phenylephrine, enhance the HPV. The potential adverse effect of norepinephrine on PVR is likely to occur at higher doses. Vasopressin. The vasopressin are cause systemic vasoconstriction via the vasopressin V1 receptor. It has relieved the pulmonary vasodilator property at low dose through a node-dependent mechanism. Is although manifested clinically as a reduced PVR after the cardiac surgery and hypotension associated with chronic PH in severe setting. Then endothelium receptor antagonist. The oral drug competitively antagonize the endothelium receptor. The example include bosentan, tazectin, and bisetron. The bosentan antagonize the both A and EB receptor. This drug prevent the endothelium receptor as well as being a pulmonary vasodilator. Endothelium is also involved in the vascular remodeling of the pulmonary vessels with long-term hypoxia. Endothelium antagonists may also slow this process. Acetazolamide. The acetazolamide is carbonic anhydrase inhibitor is commonly used in attitude acclimatization. Although the exact mechanism of action is unknown, acetazolamide is a converting enzyme inhibitor. This commonly drug used to reduce the HPV response. Thanks.
Okay. Your audio was giving a little trouble now and then, but you have covered most of the points that are required for this answer. So the basic thing that everyone has to understand is hypoxic pulmonary vasoconstriction is a protective reflex. That is the first and foremost point. How it protects, why it protects. Where is the hypoxia? The hypoxia, if it happens in the alveoli, which are perfused by a pulmonary capillary, then there is no point in blood flowing through that surrounding that alveoli because there is no oxygen to be taken up. So there is no point in allowing the blood to run through that alveoli. So nature has made it in such a way that if there is no oxygenation or air entry into a particular small alveoli, automatically there is a mechanism by which the pulmonary capillary, which is perfusing that alveoli, is able to sense that there is no oxygen available there and immediately constrict so that blood can be diverted to areas where there is a adequate oxygenation or aeration is taking place in the alveoli. So that is the way it is a protective mechanism. And this is necessary because, as I said in the earlier discussion, that not all alveoli in our lung will be opening up simultaneously. Some portion will be opening up, some portion will remain atlectatic, some will be partially ventilated. So there is a heterogeneity. It is not homogeneously, uniformly expanding and collapsing. So there is a lot of heterogeneity in the opening and expansion of the alveoli. So in order to prevent venous admixture, that is wasting that perfusion, wasting that blood going to an alveoli which is not getting ventilated, it will ultimately only decrease the total oxygen saturation and available in the blood, because the venous blood will come back as venous blood without taking up the oxygen. So that is what is called the ventilation perfusion mismatch. So this mismatch has to be corrected. For that, nature has given this hypoxic pulmonary vasoconstrictor reflex as a protective phenomena to maintain our oxygenation at an acceptable level. This is the basic point that all of us have to understand. When this mechanism becomes very intense, there is too much of vasoconstriction in the pulmonary circulation because of either a large area of lung getting collapsed, then what will happen? The pulmonary pressures, the arterial pressure will be elevated because there is a resistance to the pulmonary arterial flow. And all of us know that pulmonary artery arises from the right ventricle, which carries the deoxygenated blood to the lung parenchyma to get oxygenated. So when the pulmonary capillary level there is a constriction that reflects back on the pulmonary arterial vessels, which increase their pressure. Normally, as I told you in the last class, it should be between 10 to 12 millimeters of mercury. When it starts increasing more than 25, it becomes quite significant. And this increase in the reactive pressure in the pulmonary vasculature will reflect onto the right ventricle. It will not be able to pump the blood properly into the pulmonary vasculature. So right ventricular overwork has to be done. It will start failing. So there will be increase in right-sided pressures. It will be reflecting back on the jugular pressures. So all that consequence will happen. So even though hypoxic pulmonary vasoconstrictor reflex is a protective phenomenon, if it occurs either extensively or in a continuous fashion, it becomes pathological and starts affecting the right side of the heart. That is what we have to understand. So what conditions affect how anesthesia, especially when we do one lung ventilation, we purposely ventilate only one part of the lung. Of the two lungs, we ventilate only one lung. So we heterogenically create a collapse or an atelectasis of an entire lung, which means the entire blood supply to that lung should be immediately cut off, so that unnecessarily the perfusion need not take place, because there is no point of perfusing those lungs which are going to be collapsed. So there is naturally a severe deoxygenation occurring, because only one lung is expected to serve the function of delivering the oxygen to the body. So we land up with a situation of hypoxemia created by this iatrogenic one lung ventilation. So in the exam, they commonly ask you what are all the methods by which you will overcome this hypoxia induced by one lung ventilation, for which of course we have all the answers. We preferentially give 100% oxygen, give PEEP, give CPAP to the non-ventilated lung, this and that, or clamp ultimately the blood vessel which is going, which is not undergoing the required hypoxic vasoconstriction. So that is what is happening in these things. So I'll just show a presentation where whatever points he has prepared, I think he sent me a PPT.